class, welcome to this session. This is about medical, surgical, nursing 3. We have been discussing about the systems. And the systems for medical, surgical, nursing 3 include the endocrine system and the musculoskeletal system. This time we are going to deal with the musculoskeletal system. The key areas that we shall discuss is about dislocation and subluxation. We shall also talk about the fractures and the amputations. The main or the key thing here is we want to know when patients have these problems, how we're going to manage them in the hospitals. Welcome. Dislocation is a severe injury to the ligamentous structures that surrounds the joints, while subluxation is partial or incomplete displacement of the joints in the body. Dislocation may result from displacement or separation of the articular surfaces of the joints, and the clinical manifestations for subluxation are similar to those of dislocation. Dislocation characteristically results from forces transmitted to those joints, which disrupt the soft tissue that supports the structures that surrounds those joints. And the joints most commonly affected by dislocation include the thumb, the elbow, and even the shoulder joints. The nursing management, together with the collaborative management for a patient who has dislocation or subluxation, requires prompt attention by the clinicians. Because this is an emergency, orthopedic emergency. Patient needs to be taken care of as soon as the dislocation or subluxation occurs. Reason is because the injury may involve in the blood vessels, and the patient may be bleeding. It can also involve the nerves, which will cause a lot of pain to the patient. We are told that the longer the joint remains unreduced, the greater the possibility of a vascular necrosis. Necrosis means that we don't have enough blood supply to that area, and the tissue around that place may die off because it's not receiving oxygen and nutrients. Compartment syndrome may also occur after dislocation. Neurovascular assessment, therefore, is critical here. And the first goal for this management is to align the dislocation and then accomplished what we call the closed reduction. We can do this using local anesthesia because the patient is in severe pain, or if need be, then we can do it under general anesthesia. In some situations, we may need to do surgery, and we go and open the area for us to be able to do the reduction. And then after the reduction, the extremity is usually immobilized by use of splints, braces, tapes, or even the sling. This is to try and reduce mobility as the area heals. The nursing management for subluxation or dislocation is usually directed towards relieving pain, support and protect the joint that has the injury, and after that, reduce the mobility, let the patient rest, let alone We are supposed to take the patient for rehabilitation because remember, this is not an area that has completely healed, even after the duration of time, say 4 to 6 weeks. Let us now discuss about fractures. And we have, fracture is actually a breakage in the continuity of a bone. And we have different classification of fractures. Although traumatic injuries account for majority of fractures, some fractures are secondary to certain diseases. For instance, we know of pathological fractures, fractures as a result of diseases. We know that the bone carries a lot of calcium, and in bone resorption, calcium is removed from the bone, thereby weakening it. And this can cause pathological fractures, whereby somebody could be moving and then they happen to have fractures. That's what we are calling pathological fractures. Therefore, the classification of fractures may be an open fracture or a closed fracture. An open fracture formerly were called compound fractures, while the closed fractures formerly were called simple fractures. There is communication or non-communication with the external environment. Therefore, in open fractures, there is communication to the external environment. The bone is protruding. You can be able to see the bone, while in closed fractures, the fracture is there, but there is no communication. It has not penetrated the tissue. That's what we are calling open and closed fractures. In open fractures, that is what I've already explained, there is communication to the environment. And another classification is complete or incomplete fractures. And complete fractures is where we have a complete breakage of the bone. While in incomplete fractures, there is a fracture, we can say there is a crack on the bone, but the bone is not completely fractured. An incomplete fracture is often the result of bending or crushing forces which can apply on the bone. We know of children, sometimes because their bones have not matured completely, they are likely to have the incomplete type of fractures. While in adults, many of them usually have the complete type of fractures. Fracture can also be described according to the direction of the fracture. The direction could be an oblique, transverse, longitudinal, or spiral. Those are the different classifications of fractures, and we shall manage, or we shall discuss about the management of fractures and amputation in general. Let us now discuss about amputation. A fracture could lead the patient to having an amputation. Because when we look at the fracture and we realize that even if we try to do the repair maybe in the operating theaters, the fracture will probably not help the patient. I mean, the repairs will not help the patient much. So we decide to do amputations. So an amputation is removal of the extremity due to trauma, and therefore we do surgery. And we are told that the middle-aged people are more likely to have amputation due to certain diseases, for instance, diabetes mellitus, atherosclerosis, and some other vascular diseases. Whereas the younger people could have amputation as a result of motor vehicle crashes, farming-related injuries, or even mines. What are the clinical indications for amputations? Most amputations are performed due to peripheral vascular problems. Patients who have diabetes mellitus may have neuropathy, may have problems of blood getting into the tissue, and as a result of that, necrosis may take place. And due to that, it will be difficult to save the limb. Other common reasons for amputation are trauma or thermal injuries, and similarly to tumors, osteomyelitis, or even congenital rib abnormalities, which is rare conditions. And although pain is often present, it is not usually the primary reason as to why we shall do amputation. Because with pain and the medication that we have, we are able to control the pain. Then what are some of the diagnostic procedures, diagnostic studies which we should do before we take the patient for amputation, or even as a result of the fractures? It is important that we do the blood counts, particularly the white blood cells. And remember, if they are elevated, then this could be a sign that there could be infection coming in. The question is, should you do an amputation when there is infection? It is important to control the infection, then you do the amputation. Vascular tests such as arteriography, Doppler studies, venography or venography, all these are important so that they can show you to what extent, to what level do we have the blood supply. Because it is at that point where we do have the blood supply that will guide us whether we should do the above knee amputation or below knee amputation. Collaborative care. Collaborative care, I mean the nursing care management, whereas the other medical disciplines coming in to support one another, whereby the dietitians will come in, the doctors will come in, the nurses will come in, the laboratory people will come in, and all this, what we are trying to do is to give the best care to the patient. Therefore, the goal of amputation surgery is to preserve extremity length and function while removing all infected pathological or ischemic tissue. Our aim here is that the patient will not be made functionless because of the disease. Rather, we want, even after amputation, the patient can be able to recover and be able to do certain, although not everything, but certain activities of daily living. And the type of amputation will depend on the reason why we are doing this surgery. Therefore, a cross amputation is performed to create weight-bearing residue limb. This is one of the key important areas that we should consider before we do the amputation. That even after the amputation, with rehabilitation, the limb can be able to carry some weight when we put the prosthesis for this patient. That even after the amputation, we can put the prosthesis and the patient will be able to function near normal. An anterior skin flap with decentered soft tissue paddings will cover the bony part of the residue. What do I mean by this? That when we do the amputation, we should cover the bone together with the nerves, preferably the sciatic nerve, which is one of the major nerves, so that this patient, after the amputation, the patient will not experience some other undesired experiences. Later on, we shall discuss about phantom pain. So we are supposed to cover the bone with flaps. These flaps will be able to carry the weight by use of the prosthesis. If amputation is considered elective, Then careful assessment of the patient's general health status should be put in place. And chronic illnesses and infections are important considerations before we do an amputation. Let us give antibiotics, let us give other medications so that we treat the infection first before we do the amputation. Because when we do the amputation when the patient is still infected, chances are we might not achieve the goal that we desire. Then what are the preoperative management of these patients? We know the general preoperative management whereby the patient should sign the consent, the patient should be fasted depending on the type of foodstuff that the patient has taken. We know some other preparations like the laboratory works that the patient should have. Patient should take a shower, patient should gown. Those are the general preoperative preparations. But over and above that, it is important that the nurse should reinforce the information that had been given by other clinicians before, so that you are quite aware that your patient, by the time they are getting to theater, they are aware of what will happen to them during surgery and, most importantly, even after surgery. Meet the patient's educational needs. Get to find out how much does the patient know about amputation. Do they know whether they will have a prosthesis later on? Or the kind of amputation that we are doing for this patient, if it is below knee amputation or above knee amputation. Below knee amputation will also always be good, because remember, you preserve the knee, and the prosthesis, when you put the prosthesis below the knee, the patient will be able to walk. Above knee amputation, there are restrictions for that, for the patient to do certain activities later on. So reinforce the information or find out how much does the patient know regarding the type of amputation that will be done and to him or her. Instruct the patient in the performance of certain exercises, because we know that the patient might be in bed for a certain period of time before we allow them to get out. Chest exercises will be good, and this can help prevent such diseases like pneumonia. And even the other muscles of the body will also need to have exercises. It is important that you instruct the patient on the use of crutches. This patient, after surgery, will use the crutches. And so what position will the patient be taking while they are using the crutches? Discuss about the general post-operative management, such as the residue limb care. This patient, remember, will have a wound. Will you be dressing the wound? The answer is yes. Can the wound be infected? The answer is yes. So the general management for this patient should be there. But again, it is important you tell the patient that when they have this dressing in the ward, they have to observe for bleeding, and if it's there, they have to report. Sometimes they may feel like the dressing is a bit tight for them. They should report that to you as the nurse. And this is very important. Let us talk about the specific postoperative management. The patient has gone to theater. The patient has undergone surgery. As a nurse, the nurse has picked the patient from theater or operating rooms and back to the ward. There are those general management of the patient postoperatively. For instance, observation of vital signs. It is important to observe the vital signs. Particular of interest to our patient here is in case they have an air embolus or a fatty embolus. General postoperative care for the patient who has had an amputation depends largely on the reason as to why we did the amputation and the general status of this patient at that point in time. Monitor the wound for bleeding, as we had said. Prevent complications such as infection. Instruct the patient that they can even fall down and injure the area. And nowadays, our hospital setups, some of them have floors that are slippery, so instruct the patient that they can fall down and injure their limbs. As clinicians, let us monitor the wound for bleeding. You check on the dressing. In case the dressing has any bleeding, then you can reinforce the dressing, maybe small bleeders. But if the bleeding has not stopped, again, you can inform the surgeon who did the operation. We are going to plan for this patient on how they will get the prosthesis later on after they are discharged home. We should maintain sterility when we are doing dressing. Aseptic techniques should always be maintained because we don't want infection. Remember, this is somebody you have reduced the limb, and any infection to the bone means that we go again back to theater and reduce the bone even further. This would not be good for the patient. Sometimes the patient may have a tourniquet, though this is in rare occasions. But when the patient has a tourniquet, it is your responsibility to keep checking on the perfusion around that area of the tourniquet. We have come to the end of our session. Let us recap on what we have discussed today. The unit is about medical surgical nursing 3, which is divided into endocrine system and musculoskeletal system. And in the musculoskeletal system, we have discussed about dislocation and subluxation. We have discussed about amputations. We have discussed about fractures. Fractures, rather, they will come as a result of, the amputation will come as a result of the fractures. And we have discussed about the collaborative management and the nursing management for somebody who has a fracture, and then they'll go to theater for amputation. But not all the time that we shall do amputation. We can take the patient to theater to put in the nails, to put in the plates, but the postoperative management is similarly the same. Thank you, class.
These televised lectures supplement our robust online learning going on our MKU online platform. You can view more on our televised lectures via our online platform. We are in a digital era, and Mount Kenya University knows this. The following are the steps to follow so as to complete your online application. Download the application form from the website www.mku.ac.ke. Attach copies of your academic certificates and ID. Pay the application fees via M-Pesa pay bill number 270988. Your ID is the account number. 2,000 shillings is the charge for a postgraduate. You can also deposit in the bank accounts provided on the website. Then email all the above to apply@mku.ac.ke.